I have few points, and then perhaps we can go over to the discussion. Both of you actually mentioned about quality of care, which is provided by doctors, and even quality of medicines. There are studies which have shown, and government official reports which have shown that the quality of medicines in government sector is actually found to be much worse than the quality of medicines that is present in private retail chemist shops. So the rate in government shops is around 10%, while it is around 3 or 4% in private retail chains. So that's the reason why, as you rightly mentioned, a lot of people might be apprehensive to buy medicines from a government store, even if it is free. Additionally, we didn't talk about this much, but perhaps quality of infrastructure is equally important. There are states in which absolutely no PHCs or CHCs meet the quality of standard mark that is supposed to be met by them. So that's like a grave area of concern. We have already seen a lot of newspaper articles and investigative journalism articles which have shown that these facilities are so poor when it comes to waste management or even in terms of basic sanitation facilities that I don't know how anyone even expects to be treated well or get cured in these facilities. Lastly, I think there are burning questions about NMC bill, doctors, and lack of availability of doctors per se, because of which one of the reasons why this bill was introduced. So financing should perhaps focus on, how to bring doctors to the health system, as they're lacking in a big way. So I open the floor to questions. I request other members if they can join in on the table, so it can be a better interactive session. There are seats empty. So if you wouldn't like to join in on the table. Go ahead. Any questions?
Yeah, so basically I have many questions, but I'll stick to only two. Number one is, I'm sure Sumit, you have, and you both must have seen the National Health Accounts report. If you look at the primary, secondary, tertiary care expenditure breakup for public and private sector, the public sector spends, and this includes both states and the central government. So that itself is of whatever the country spends on health in the public sector from the government, 50% of it is 50 to 51% is already being spent on primary care. And as we all know, primary care is cheap. Secondary and tertiary care is still very expensive. So almost half of what is being spent on health is already being spent on primary care. So how much more should we aim to, spend on primary care? And sub question of that is, do we have the absorption capacity? Like, can we spend? Just pumping in money doesn't help. Can we spend? And so how much is the question, number one. And the second question is, there's a huge problem of trust, not only in the towards the public sector, of course, not only in the patients or the people, but also in the providers. So, because I was involved in some work on the capitation-based model for primary care in Kerala. They are already doing this Clinical Establishment Act, and the private sector is already very furious with the government that why are you asking us to declare all those things that are, private, our information, why do you want that? So there's already a sense of mistrust. And then, of course, you know the payment issue. The private sector doctors, the RSBY experience was so bad that people, had to close down their hospital, 60, 70 lakhs, 1 crore of pending amount. So I'm sure other countries must have also, because you've shown us so many country experiences. Has anyone ever written about how to deal with the trust deficit and what has been done about that? Those are my two questions.
you know, what that brings, and I think I'll start and probably limit to the last part of the question, that how has countries done that, and this is where is and my most latest news, because I've been more preoccupied with that area of, and I increasingly believe that it's all about the interaction between political incentives and economic incentives. All countries in the world with strong, responsive primary care systems, forget UK, UK have started it 50 years back, but countries like Brazil, Mexico, Thailand, Iran, for example, have done that, where both of these has combined together well. And to do that, it's easier said than done, of course, but there are potential promise for, in a country like India, it has to be through decentralized political agency. Whether that is possible immediately, near future, I don't know. But before we are talking of reforming the health system, and it works equally for reforming the education system. The only way, if we at all might do it in the next 30 years, 40 years, wherever, has to be through a reformed, decentralized political agency. Because in a democratic country, where elections are held, if a functioning of a PHC or a district hospital is in no way related to the electoral chances or prospects of a candidate, it is very difficult to either bring in the people or to bring in the government to deliver, so that interaction of the political market, of the incentives and disincentives, doesn't go. It sounds very complex, and it sounds very utopian, that can this at all happen? But that has happened in Brazil. When Brazil started in 1988, it followed a period of military dictatorship. We haven't experienced that. Mexico, even worse. So Iran, we know that none of these countries were countries which had, so India of today has far mature, strong, old institutions can do. The thing is, how do these institutions start to move? But how we do it is not a job of a health economist or a economist, for that matter, to talk, but it has to be on that. So the issue of political economy, of making the health reform, has to be on the table. Models are there. There are a lot of models. You can pick and choose what adapts best to Indian example. Primary care, secondary care, tertiary care. Why I focused on primary care? Because in secondary, tertiary, as Sisir was saying, we are at least aware, we now know some broad contours of the model that the country will follow. The nuts and bolts we need to talk about. In primary care, we don't even have an idea of the model to do. But to do that, the route has to be through the decentralized political agency. I don't at all believe the learning, I couldn't talk of that. The NRHM learning, the aspiration of NRHM was actually that. NRHM wanted the 10,000 rupees to sub-center was nothing. But what it aimed was to promote this culture of decentralized health system governance. Sisir will agree, sometimes I feel that we don't talk about, and that is a typical problem in India, which I realize every day, that we are a big fan of new models and doing new things. But something that we have in NRHM, we have tried to do a lot of new things, and which has been in place for close to 15 years. But are there any learnings, institutional learnings from there? We are not talking about that. But that had a lot of those philosophy of doing that. I think it is important to bring some of that into the discussions of the present reform. And some of these questions, like you're talking of absorptive capacity, you are talking of, but we initially started answering these questions through an NRHM model 10 years back, 15 years back. What do we learn there? We are not even talking of that. And I don't think that is a way. That needs to be, I don't believe that there is no learning experience from NRHM.
Just to add
Yeah.
quickly. So, political accountability, one of the easiest way to do that is to ask this question: do you have the basic data set, infant mortality and maternal mortality data, not by district, but by
Assembly
constituency? That's the first question that we should be asking in order to instill accountability. Unfortunately, we don't. Is it hard to do? No. We just don't have the data. That's one way to enforce this.
Great. Any other? Go ahead.
So your question, if you really want to have an answer to assembly constituency, we have the data by districts and we can just combine it and just give it data. It's about asking a parliament question about it specifically and talking about it.
The district and the parliamentary constituency boundaries do not match. No, you cannot do it.
So one has sub-district data also, one just has to collate it in that sense, and one has to ask and give a platform for asking the right question. We have the data. We have the data. She is sitting here, she's looking at all the RCH in Ministry of Health. She knows we have the data. It's just about asking the question.
Look, what I can tell you is Brazil has municipality level health data, which they started 88 around.
90s, yeah.
So if you look at, it's not readily available, that's what I'm saying. If you look at the district.
No, it is now even readily available. It is now even, just you need to understand it of Portuguese. It is even now.
No, I'm talking about India.
Yeah. Sorry.
So DLH, District Level Household Survey, is the mother of all surveys about infant and maternal health, right? They don't ask the assembly constituency identifier. You don't have the parliamentary constituency identifier either. I can do it, but I have to do ArcGIS, I have to do QGIS to figure out which center, in which boundary it learns. I have to download the shape files, do all that of mumbo jumbo. Instead, they could have just added these two notes: where is the household sitting, in which parliamentary constituency and in which assembly constituency. It's not there.
Village, for example, like when the village identifiers were there, but
they jumble the village identifier, so you don't know. You cannot go below district or sub-district level to figure out from survey data what are some basic health indicators.
Actually, I was also surprised to know that the DLHs and the NFHs are actually not really conducted by the order of government. It is being held. There is this
USAID?
USAID, yeah.
USAID actually helps out. They have a very robust system through which they do it, and everybody is brought on board on the methodology. So we can talk about the methodology of the NFHS survey. Now, DLHS will not happen now. It has been discontinued. NFHS round 5 is happening at the moment. It's about, we just have to suggest the methodology to the IAPS. I think that is the way we need to go if we want solutions.
Yeah, so I'm just setting the problem. I'm not trying to say that that it cannot be solved. I'm just saying that there's a lack of this data set that should be there. The other thing is we don't have a repository of, for example, if you want to figure out how many, the HMIS is there, I know that, but the data quality is really, really bad. If you just ask a simple question, how many nursing homes are there in a given district?
Not the purview of HMIS. That it does not cover that.
I'm not talking about that. This is a different issue altogether. I'm just talking about if you want to bring in political accountability, you need to know these indicators at various geographical levels. We lack currently.
Has also been addressed by the Clinical Establishment Act, which was floated. There was a lot of resistance by the states because health is a state subject and not a central government subject. So every state has to accept it.
So I think it's not the lack of data. I think primarily it is the integration of the political system with our health system. Like there is, I think there are very few meetings which are held with DM for such significant health issues. So and that too at a very very cursory level. Not much attention is paid. So I think data is available, but the seriousness and integration of the political system, accountability of the political system, that is lacking. So I think it's the political commitment, and we have to change that is more
Priorities and the
important.
priorities. We don't have health as a priority. And for the first time with Ayushman Bharat, it has come to a center stage. At least we are giving it a priority. We are making it a political agenda in terms of a political manifesto of a party. It never happened before.
No, I hope these information are used properly. For example, I'll experience one story just to tell you how grim the sum of the situation is. And this is 2 years back. Things might have changed. I was visiting a village in Jharkhand, and I was curious to know how the data actually reaches the central database, mother-child tracking system, which is in place, right? So first of all, the data is essentially in the mother-child card that is given by the state to each and every mother, which has the entire record. And the copy of the data is with this big registers that sits at the subcenter level. Now, these data are again given to somebody at the block level. There is a single person to upload the entire data into the system, and basically over every meeting the ANMs sent these reports, just submit it to him and just asked him how far have you entered. He said there's a 2-year time lag in entering the immunization data. So this is bewildering. This is just a one example, right? Now, what policy decision you can make if you have 2-year time lag in immunization data? You cannot do anything.
I will be very happy to listen from her because it has to be done on a monthly basis. On a monthly basis, the CMO takes the meeting and everyone has to put the data, and on a monthly basis it is checked by the CMO. I know that I have myself submitted the data and it is being checked. In most of the states, it may be an outlier. Your example may be an outlier, but the systems are like this, that every month the CMO has to take the meeting of all the data that has been coming from subcenter, PHC, CHC to the district.
Many things at the paper. Just another example. There is a field in MCH, mother-child tracking system, which is supposed to be the phone number of the primary caregiver, right? I just could not get the data, but I was interested in that phone number because we were thinking of pushing some SMS messages or calling the mother about some immunity immunizations. All the phone numbers are the same. It's the phone number of the ANM that has been recorded. So I don't want to make a lot of fuss about data, but all I'm trying to say is just to get back to your question, if you want to bring in the trust element to it, political accountability is needed. You need to hold somebody responsible for the current level of health, some measure of health.
Yeah.
And it's with the current data sets that we have, it can be done. It's a tremendous amount of work. It's not that simple.
Yeah, no, since it all went into information, and again, being an economist, I can't prevent saying this, that India must realize information is a very important economic good. An economic good works when there are incentives and disincentives. India is a country which produces some of the fantastic data in some entirely different areas. There is no reasons to believe that.
Which field? I just want to know that.
No, I
Which
fully
will be
agree with
fantastic.
you. I fully agree with you, and I think the topic of today, there will be several comments which I thought I would make, but I want everyone to come back to the topic. The topic of today was challenges in the
Yeah.
challenges in the
Financing
Primary care.
financing primary health care. So I would like, uh, I don't want to go into those details that what are we doing, how we are collecting the data, how things
Yeah.
have improved, how we are moving in the right direction. Yes, she has done a lot of, already said that. But I really want to know three things. Now that Ayushman Bharat is there, it has two limbs. One is the preventive promotion, one is the secondary tertiary. So here we are providing and here we are kind of giving a financial protection. So my questions are whether we are going in the right direction. Is the expenditure enough? And how we can make it more cost effective, or what methodology or what procedures will make it more economically suitable. Since you guys are esteemed economists, I would like your opinion to know on these issues.
Yeah. I mean, see, a lot of it we have been saying, and some of the answers lie in different. So, for example, a very quick back of the envelope calculation tells you that a simple fact of providing this 70% of total expenditure, private expenditure, out of pocket expenditure is on drugs. And there are no statistics again, but we can estimate that roughly 50% of that would be on primary care drugs, common drugs, either for acute ailments or long-standing chronic disease ailments. Now, if we are thinking that people won't require to pay for these drugs out of pocket, and they will have these provided from the HWCs under Ayushman Bharat, that expenditure that is being now made by the people has to come, has just simple, has to be.
So you mean to say that we are moving in the right direction? This process is right?
See, it's not, it's because the model is not changing, as you were saying. The model of providing care.
The model has already been chosen. We have to devise a model which fits in our system. There was an existing system. There were existing subcenters. There were existing PHCs, and recognizing the huge burden that NCDs are going to play. So it was thought that instead of initial those 6 RCH services, it has now increased to 12, and that includes your diabetes, hypertension, cancer, and these are the 3 major illnesses wherein the screening is also taken care of, the recurrent medication is also taken care of, and the investigations, the diagnostics are required. So with utilizing the data, utilizing the existing system, they were already delivering RCH, so it was thought that we can piggyback another 6 set of services and then equip them and then make them and convert them. So idea is that. So my purpose is saying that economically are we going in the right direction, and whatever we are spending, is it enough to take care?
The spending is clearly not enough. The spending is clearly not enough. It can't be enough.
Where you want more budget? Where should we spend more? What should we do more so that out of pocket expenditure the patient?
The spending has to be, as she started saying, there are 2 components of it. If you are talking only of NCDs, then screening. Now, who will be doing the screening? It has to be notionally.
We have gone into the highest level, the universal screening, If we are doing universal screening for diabetes, hypertension, and the 3 common cancers. It is like population enumeration, and then everybody who's above 30 years of age is going to be screened for these ailments. You cannot go beyond that. What is beyond this?
I just want to add this from the entire lecture only, the answer probably. that what you mentioned was like primary health care or the health and wellness center, it is the gateway, right? And then in this entire package we are doing two things. One is I think one is retaining and another is delegating. So health and wellness center is retaining and tertiary and secondary care
Is
is
delegating, yeah.
Okay. So now when we are working on the economy model, I think for the best fit, for the most cost effective services, we actually have to focus on health and wellness center. Best health and wellness centers, equally accessible, affordable to everyone. Why? Because if we are having a good gateway, we are having less people going to the secondary and tertiary services, less people going to secondary and tertiary services, more cost effective services. So actually we have to work on a very good and very efficient model for health and wellness centers.
I think this
Can I-
is,
can I
this is-
rephrase
this is-
your
this
question
is-
which you-
this is a very well known evidence that if you invest 1 rupee on preventive and promotive care, it gives you 40% returns, whereas it reduces to almost 10% when you go to. So there's no harm in pumping money in the primary care, because you are taking care of dalis, you are taking care of rehabs, you are taking care of tertiary care, which all becomes cost incentive. So here, even if you spend 1 rupee more than the tertiary care, you will have to spend 10 rupees less there. I mean, that's a very well known preventive and promotive economics which has been done years back. So my question is that if we are not investing enough, oh well, actually I wanted to know that, because since there are so many states, I heard somebody talk about you worked on Arogyashri, so I wanted to know what model would have been best to integrate the state models into this kind of a thing. And let me tell you, there has been a WHO study, they have already come out on an NHP when the National Health Protection Scheme was made. Then there has been a comparative study, they have studied each and every procedure, that what is the range of say suppose I want to undergo cesarean section, the range is from 10,000 to 50,000 or maybe a lakh. So they have sort of done a comparative study as to at what level how much expenditure happens. All that data is there, and right now the DHR, the health research team along with the Niti Aayog, they are already going into the cost effectiveness of packages. They are well into it, they have a lot of data. If you want, you can get in touch with them. Lot of work has been done on the costings of.
So they're doing costing only, they're not doing cost effectiveness. I'm closely
Yeah,
associated with it. They're only doing costing, not cost effectiveness. I am from DHR only.
Acha. But I guess they are doing working around costings.
Only
and
costing of the services,
Okay.
not cost effectiveness.
So, you know,
costings are available.
just to answer your question, because I cannot definitely say, because it's a very detailed study that one has to do. What I would say is, from the Andhra data that I have studied, there was a huge problem about hospitals will down the line, one day or the other, will claim for change in the reimbursement rates. You should be prepared for it, because inflation is not stagnant. Even though we are inflation targeting, inflation would be there, and the hospitals at one point in the future would demand reimbursement rates to be increased for most of the procedures.
So this is what I think.
The question is, how are we going to address that? We need to have an index of medical inflation. Okay, so for that you need to collect periodical data on medical costs or prices of medical devices, different things. You need to do that survey so that when these hospitals come back to you 4 or 5 years later demanding a change or rather increase in reimbursement rate, you can tell them, well, in the past 5 years we had been collecting this price data from various points. This is the rate of increase in price, here you go. They should not, because that will be another political debate, because they will know that this scheme is successful. I can take the government at ransom by saying I am not going to treat these patients anymore, and then the government has to accept whatever they're demanding, and there'll be again huge fiscal burden there. So you need to have a scientific way to shut them at that point telling them, here is the reimbursement rate, we thought about it 5 years ago, and here is the data on the
And
basis of
another
which
input can be the region description, right? The difference between rural and urban areas, like the cost is different between these two regions. The reimbursement rates also have to be different.
So,
between
you know,
these two
that
regions.
is a contentious issue. I
No,
mean,
actually not. They are gone with the packages. The Ayushman Bharat, if you see.
I mean, that's the point that I'm making. That you know,
No,
we
but I
already
think
have
this suggestion is good, that one should know, and I mean, since you are there, so you can start working from day to day, that what would be the rates, you know, some kind of a formula, like you have EMI calculator ki 10 saal ke baad itni EMI hogi. Something
That's
like
a very
that.
good suggestion from Sisir, because you know, the present idea is to fix a particular rate which will continue for some time, but which is going to be very damaging, I would say, for the whole healthcare provider, for the market of the healthcare providers, and it could be disrupting the market.
yeah. So actually, there was a strike in 2013. If you plot the data of Argyshri utilization, you see that 2013 huge drop because they demanded higher packages, and then yeah. So then there will be negotiation between the government and the hospital, and these hospitals are actually very influential people, and they will try to negotiate different rates for the procedures that they like. The thing is, there will be a revision in the reimbursement rates, and those revisions might not be reflecting the market prices. What might have happened is actually some reimbursement procedures where the prices had gone up significantly. There are some others where there had been no changes, and there are others where actually reimbursements did decline. We have not, I wouldn't say conclusive evidence, we can just see in the data for the procedures where the price reimbursement rates were substantially higher, utilization rates also increased. I mean, this is something that we call supplier-induced demand, because this is also called upcoding in the US market, right? So the Niti Aayog, or whatever the agency which is actually determining the reimbursement, they should be very careful and aware about this.
Deepika,
Fortunately, what has happened is...
Can I request, since we are over time, that we take this discussion over tea and coffee?
Sure.
Yeah. Sure. I mean, we can go ahead and discuss outside, but you can
So
shoot
one
your
last
question.
comment. I have one comment regarding the primary healthcare financing. So I did some back of the envelope calculation on the CGHS. I would say which is the only functioning comprehensive scheme which covers both primary to tertiary everything.
Exactly.
So and it also boils down to the political economy, because there is political economy within CGHS to treat all kinds of give all kinds of care. So comparing it with our regular health system, where any common man gets to, I mean, the government spends about 1,000 rupees per person, state, center combined, primary to tertiary. This is before Ayushman Bharat. The same, if we compare it with CGHS, it is about 5,000 rupees per person. So at least we have to spend 5 times more.
Yes.
To cover the entire gamut, if we have to give the same quality of care as...
If it has to be comprehensive.
Yes.
So, I mean, what Madam was saying is a certain number of NCDs, but you know what I got an impression, and I was talking of, is not only few other NCDs, but a more comprehensive for all these.
What she was saying,
Yeah.
they've added on extra. There were only
Yeah.
6 essential services at PHC earlier. Now there are 12. So we've added in the Ayushman Bharat.
That was just to mention.
Yeah,
Yes.
yeah. But I think the idea was, I mean, even indicating is a thing like a comprehensive CGHS thing for the whole of the population. So if that is what we aim to go to, and he's saying like it's 5 times. So I was expecting even a lot more, but that is the kind of aim. So the paradigm which aiming, you were saying that going in the right direction. So that would be like CGHS for all. So where so
That is the starting point actually.
yeah,
Thank you.
yeah,
It started from that only.
Yeah.
Once it was thought that why it cannot be omnipresent
Yes.
to them.
and that way then the budget upscaling has to be huge, and that is the normal thing, that the 70% which people are paying now, that goes to the public budget. So then the upscaling, which is pretty obvious.
Thank you. Sorry, let's just go ahead. Thank you so much, Sumit. Thank you so much, Sisir. And thank you all the participants.
Thank you very much.